Welcome. And we'll get started with what are some of the most common hip injuries that you see in dancers?
Right, I'll start us off. So hip injuries are very common in dancers. They're probably second only to foot and ankle. There's a wide range of different types of hip injuries that we see. So it can be something as benign as just a simple strain or just overuse, some tendonitis, bursitis. Then kind of moving along, you might have heard of snapping hip, or actually it's called dancer's hip. Impingement is common in dancers, as well as labral injuries, and dysplasia, or a shallow hip socket, is also very common in dancers. I'll get into that in a little bit too. And then other things, more like early arthritis can be a possibility as well. So wide range, big spectrum.
Yeah, I second that. There's definitely the top kinds of diagnoses that we see as physical therapists, as well as they come in for rehab after seeing the doc. The injuries often stem around the amount of mobility required to do the things that dancers have to do, and also the impact related to their activity levels. So those two things kind of coming together oftentimes lead to a lot of the things that we saw. So definitely a lot of managing that mobility leads to problems, whether it's tendinopathies or more kind of joint related problems like you just said.
Yeah, I was just going to say, kind of going along with that mobility, one of the big things is kind of the extreme hip motion that's really demanded of a lot of dance types. So especially ballet, because you're expected to get your leg into different, what we call supraphysiologic or not normal hip positions that put stresses on the hip in a way that's very different from any other sport or activity.
Right. I think that's what makes it so interesting to have the experience of or the opportunity really to work with performing artists. There's a kind of a tendency, I think, amongst some folks in the rehabilitation world to say, well, maybe you can cut down on that movement. Maybe that movement isn't good for your hip. And that's not, we can do better than that, right? We have to try and help those motions that go beyond some of the normal motions maybe associated with sport sometimes, or some of the other things that hips do. And we have to really encourage folks to be as strong as possible and be able to do those movements to the best of their ability. We want to try and have dancers be the best dancers that they can be, not discourage them from doing the things that they have to do. And that takes learning and understanding what those hips go through. And like you said, those movements that are outside the normal range of typical human movement are really what we're dealing with.
Yeah. I think another thing to just add about hip movements, going back to ballet, it's the basis of a lot of dance forms. And one of the things that we really need as ballet dancers is turnout. And that comes from the hip, and that it can place tremendous load on the hips as well as the other joints if it's done improperly. So kind of understanding that can impact hip injuries moving forward for a lot of dancers too.
Do you see folks that, given the amount of turnout that often is necessary in dance, what kind of correlation, if any, do you see with their availability of movement and their ability to kind of perform it in the dance world? In other words, is it always just that folks that are maybe excessively mobile have more problems, or folks that are not mobile enough have problems, or do some people compensate and some don't?
Yeah, so I think it can be both. So it can be on both ends. So if you don't have that turnout and you try and force it, so turnout really, again, it comes from the hip. So it a lot of it's based on how your hip is shaped, and some of that we can change and some that we can't. So we can kind of stretch the muscles, strengthen around the hip to really use those external rotators to help get the turnout. But if you're pushing it, then you're going to do some compensatory things which are going to have downstream effects. So if you don't have the mobility from the hip and then you kind of force it, then you are going to torque the knee and then also potentially the ankle and cause a lot more issues than just hip pathology. On the other side of things, you kind of brought up with too much motion, so the people that easily get that motion. So if you are able to get the turnout and that high super physiologic hip range of motion, the extreme motion, you might be ligamentously lax, as a lot of dancers are, which can also bring risk for injuries around the hip, but also injuries around the rest of the body as well.
Yeah, as you described, for sure. And that kind of fits exactly with what we're seeing from the poll results, right? Like that we're going to talk more about some specific hip injuries for sure. And it's good to see in the second question how plurality of folks are saying your favorite cross training exercise, and it's strength training, and that's encouraging. That's really great to see, and we're going to talk about that and how that is probably should be the first thing that is done to keep your hips as strong as possible once they're in a good spot. A lot of contemporary and ballet dancers.
Yeah. Nice range.
Yeah, that was great. So, I hope in a little bit we'll get more into mobility, how you can increase your hip mobility and kind of show some examples of that. So we'll touch on that in a bit. But in terms of snapping hip syndrome, going into more specific injuries, what are some common mechanisms of injury? What typically causes this?
Yeah, so snapping hip is there's actually different types of snapping hip, which I'll get into. But snapping hip is also known as dancer's hip, as I mentioned before, so it is super common in the dance population. Probably the most common type of snapping hip is from the psoas tendon. So what does that mean? So what are the symptoms of snapping hip? It's when you're lifting your leg, externally rotating, you feel or can actually hear a snap or a clunk or a loud sound coming from the front of your hip. It becomes a problem when it's painful when that happens. So what most commonly is what causes a snapping hip is a muscle rubbing over a bony prominence, and underneath that muscle is something called, or around that muscle is called a bursa, or like a fluid-filled sac that can become inflamed if the tendon or muscle becomes irritated. So the most common muscle for that to occur with is a psoas tendon in the front of the hip, which is really used a lot by dancers. Every time you lift your leg forwards to the sides, you're activating the psoas. It's also one of the stabilizers of the hip. And when that rubs over the front of the hip joint, it can cause irritation, pain, and that snapping sensation. The other type of snapping hip is external snapping hip. It's on the side of your hip joint. And that's when the IT band is actually rubbing over the greater trochanter. Sometimes it can be the another muscle around the back of your hip, or the gluteus maximus. And that is when you can feel a shifting or a clunk or snap on the side of your hip joint too, which can also be very painful. Some people can even describe it as feeling like their hip is dislocating or popping out of place when that occurs too. And then there's also another form of snapping hip is when there's something going on within the joint, when you can feel kind of a catching or a snapping within the joint. And that's more of an issue that occurs around the cartilage or the labrum, or some other kind of pathology within the joint itself, as opposed to being the muscles around the hip.
And that's great. And the mechanics that kind of lead to these challenges often there's all the passe that has to go on in dance, all of the forward lifting of the leg that happens because, as was mentioned, that the psoas is that primary hip flexor, but it has so many other roles as a hip stabilizer, as was mentioned, and definitely as a gait muscle or walking muscle. And so when it's used in that capacity over and over and over again to lift the leg forward, it really needs to be trained a little bit differently to be able to do that. And then you combine that with the turnout that we already mentioned. So you have a hip that's maybe a little bit more prone to go into external rotation. You see these folks walking down the street. Sometimes they walk with a little bit of a turnout even when they're not dancing. So there's a little bit of a tendency for that hip to externally rotate. When it does externally rotate, the the ball tends to move a little forward in the socket. So now that's the mechanism that oftentimes can be responsible for that tendon kind of snapping over the front of the hip. So you're combining two challenges, a lot of use of the psoas tendon and the hip maybe being in a position where it's a little bit more predisposed to that. These are things that's challenges that have to be met to try and optimize the mechanics of that hip socket. The lateral snapping hip, it presents differently.
Mhm.
What do you usually see as far as like differentiating patient complaints in those two things,
Yeah.
Dr. Buza?
So definitely the location of the pain, because when patients do come in with that external hip, snapping hip on the side, they will point to the side, and sometimes it can be actually visible. So you can actually see it snapping over the greater trochanter or feel it from the side, as opposed to the psoas, which is deeper, so it's not as obvious. And that's the one where some people even feel like it shifts out of place. But there are some exam maneuvers that you can do to just help to distinguish that, as well as palpating or pressing around the area.
For sure, and the same is true with the internal cause potentially of a snapping hip. There are some tests that we can do to differentiate those things. Is it fair to say that unfortunately sometimes these things don't happen in isolation either?
Yes. Yeah,
right?
that is a great point. So they're often occurring all together. And when you have inflammation, everything around the hip is pretty tight and close together. So when you have inflammation in one aspect of the hip, it's pretty common that it's going to impact the rest of the hip. And plus, as I'm sure you've seen a lot and you're going to get into, but when you are not activating certain muscles properly because maybe they're injured, overused, then it kind of throws off the mechanics throughout the hip joint, which can lead to further injury in other areas of the hip too.
Right. No, you hit the nail right on the head. A snapping hip challenge is something that when we see it, maybe I'm getting a little ahead of myself, but when we see it in the rehab time frame when they're coming in for physical therapy, I always look at those people with a lot of hope, as long as there's not anything really dysfunctional underlying it, like a labral tear or a significant hip dysplasia. So because a lot of times it is more about learning a little bit more about motor control and timing, maybe a little bit of activity modification at the beginning. And by that, I mean, if, for example, like doing Pilates hundreds might not be the best choice of side exercise for folks that are having this problem, or floor bar or something like that, where you're constantly, in addition to all the pasa you're doing in class and everywhere else, you're lifting that long lever off the ground over and over and over and over again. So I'm always very optimistic about how we can help these folks if we make some simple modifications in the short term, and then teach them some longer term changes to their exercises.
Yeah, definitely. I think catching it early is really a key thing too, so that we don't develop other issues. So, because you can work on it very, very simply by activity modification, like you said, and a lot of exercises I know you'll talk about too.
For sure.
Yeah, I know you guys mentioned a little bit about labral tears. So can you talk a little bit about labral tears and how, dancers might get that, or how they can decrease their risk of getting that?
Yeah, so labral tears are very common. So just so that everyone, maybe not everyone knows what a labral tear is, but the labrum is a piece of cartilage that lines the socket of the hip joint. And it is very prone to injury, especially in dancers, because like we were talking about before, you're getting your leg up into different positions that can put stress on the labrum. Additionally, just the shape of the hip joint can also place stress on the labrum, and in two ways. So either in impingement, which is when the socket and the ball can impact each other in different ranges of motion. And then also with dysplasia, or a shallow socket or under coverage of the ball by the socket. Because when that occurs, it can put, if the ball isn't being perfectly covered by the socket, then the labrum sees a little bit more load from the femoral head. So the labrum helps to stabilize the hip joint. It has a lot of nerve endings, so it can be a source of pain when it's irritated. The key, you had asked about preventing some labral injury. So one of the key things is maintaining strength around the hip joint. I can get into a little bit more, but
oh no, there's so many things I could piggyback off that. So the 100% dead on accurate. The strength is the prevention, right? It's the as Dr. Buza mentioned, the labrum is what we call inert or non-contractile structure. It's part of the stabilizing mechanism of the joint. So it's one of the structures of last resort, if you want to look at it that way, especially in some positions. And if the timing and control and strength of some of the musculature around the hip isn't what it should be, given the demand being placed on the hip, then that structure is going to get stress on it more than it should. So the prevention is not bumping the car into the car in front of you when you're parking. Like you're trying to keep some space away from that labral structure. The one of the challenges, unfortunately, is that if there has been some trauma to the labrum, as was mentioned, there is a lot of sensory component to the labrum. It's not a unintelligent structure by any means. It provides a lot of feedback to the central nervous system about where your leg is in space. And if there's been, if you've dinged up the car, if we're going to stick with this analogy a little bit, then you affect the ability of those nerve fibers to get information back to your central nervous system about where you are in space, which unfortunately is kind of like driving blind a little bit. Like you're more likely to ding the car the next time. And so there's a little bit of a spiral here. If you have one injury and it's not managed properly, you're probably, and I'd love to hear your thoughts on this before I overstep, but like you're probably a little bit more likely to have your next little dink to the labrum until you go on and you get one bad injury, unfortunately.
No, that's exactly right. I like the car analogy. I'm gonna use that.
We don't drive in New York, so it's kind of like
I know, I don't
probably not fair to make comments about our driving ability. We'd probably all be hitting everything if we drove more.
No, I think you're exactly right with everything you just mentioned. Completely agree.
All right, so kind of similar but different. Can you talk about tendonitis and how that's different from labral tears and snapping hip, and how dancers can also try to prevent tendonitis, or how you normally treat it?
Yeah, tendonitis is extremely common in the dance population because we're always overusing the muscles and tendons surrounding the hip joint. So tendonitis is basically inflammation of the tendon. And we're talking specifically around the hip, and there's a lot of muscles around the hip and a lot of things that can become irritated. And you were just asking about how it can relate to labral tears and everything. You can have all these together, and they commonly do occur together. The most commonly, especially with snapping hip, when the psoas is snapping over the front of the hip, it's going to become inflamed. The psoas is a tendon, and that will result in some tendonitis as well. So I guess the most common areas to see that kind of tendonitis are really in the hip flexors and the front of the hip, as well as on the side of the hip. The gluteus medius and minimus are probably also very common, as well as the hamstring. So you can kind of go all directions around the hip joint. That's what I see commonly happen. I don't know how you feel about that also.
Yeah, no, 100%. And I'll go into the patient population side of it too. Tendinopathies or tendonitis is different types of tendonitis are definitely one of the things that we see more commonly. Unlike what we discussed a moment ago, this is a contractile tissue. This is something that moves us, that contracts, that it's part of your muscle. Like tendon attaches muscle to bone. The tendon doesn't get a lot of blood flow, and that's why we tend to have accumulation of micro trauma there, and it eventually leads to pain. However, what you have going for you is that it can heal pretty well, whereas structures like a labrum, the non-contractile structures, really don't heal as well. And to be fair, you can get by with some small labral tears and be doing okay. Most of us, if you looked at our hips, if we've been active at all throughout our lives, we have some. But for tendon injuries, they can heal. They heal a little bit more slowly than a muscle injury. But I like to bring in the patient demographic side, or the age and the types of patients that we see often as dancers, because this does tend to skew a little bit more away from some of the younger dancers who maybe can heal a little bit more quickly, who maybe can recover and handle some of the abuse, honestly, that they're given their bodies. Whereas as time goes on, without sufficient periods of rest, without taking care of your body a little bit, that ability starts to change as we get a little older. So these are injuries that we tend to see in more experienced dancers, for sure. Probably both. I would think that that's actually fair to say too. The labrum problems too, unfortunately. But it's just my first moment to get on my soapbox and be like, take care of your bodies, because we get very used to what we can do when we're in our teens and 20s, and then sometimes it surprises us later that we don't feel like we're doing a significantly different amount of volume of rep, but then all of a sudden we get this aching in the side of our hip, and we have a great orthopedic surgeon telling us, like, you've got tendonitis in your gluteus tendon, and you can kind of prevent that by taking some care about the volume of what you do, giving those muscles and tendons some time in between your rehearsals and things.
Yeah, definitely. And going back to your strength training, making sure that you're doing it the right way too. So even if, taking care of yourself and your bodies, just want to make sure that you're not also overdoing it and activating the muscles in a way that's going to lead to further injury too.
Yeah, easier said than done, right? I mean, we're all guilty of it. Like we all try and get after it sometimes, especially all the time. Like we do it at certain times. We all do it. But it's about recognizing that there's been a significant change in volume and seeing that coming, and then being able to give yourself some time in between periods that are really, really busy. As it's kind of like a side tangent, and this is one of my biggest kind of bits of information that I constantly try and instill upon dancers, especially the ones that are ready to listen, is that idea of periodizing your year. And it's just, there's so much demand placed on the schedules of dancers and performers that they don't get the opportunity to do what other athletes get to do, which is have a clear preseason, in-season, postseason, off-season. And instead, they're just getting, a very high volume of work all the time.
Right.
And they get like a week or two off, maybe a little bit more around the holidays, but even then they go do nutcrackers or they do something else, right? So there's always the opportunity to work and the need to work, and hopefully there can be some way that you can balance those things. Like, please do.
All right, so I'm going to do a plug for, if anyone has questions, you can use that Q&A button. You can see there's a little notification there. So I'm going to throw in a question from the Q&A. Someone asked about, could you mention any tests on how to explore the right activation of hip muscular patterns?
Do you want me to go with that one?
Yeah.
Yeah. So that's a great question, because you want to try and identify the usefulness of your test, right? There's lots of tests out there for hips, whether it's looking at alignment and more structural things like a Craig's test or something like that. And then there's maybe a little bit less out there about what are the right things to do for the more dynamic and motor control components. So what are some of the things that I like to use? I'm going to start simple. Pelvic tilting. Like, can the person dissociate their pelvis from their hips, whether it's in quadruped or supine? an active straight leg raise, which is just having the person lying there and lifting their leg a few inches off the ground, applying maybe a little overpressure to that if they seem to do okay without it. What you're looking for there is whether they're able to maintain lumbopelvic position while they lift their leg off the ground. It tells you a lot about what they're, doesn't tell you a ton about core strength necessarily. It tells you about whether they're able to engage the muscles properly and hold their core stable when they lift their leg. Then I'll go into looking at dance specific movements for sure. Just looking at simple pliés and how they do in parallel versus turnout and what their ability to sustain and maintain a functional neutral position of their pelvis and low back looks like. So I'll keep it dance specific for some parts of it, but I also will do some very, very simple things that you would do with a patient who, like a low back patient or a low back or a pelvic pain patient. Things that we use there, but of course you're looking at it through a little bit of a different lens because these people really have to have very, very good control. And not to get too ahead of ourselves, because we'll talk about this when we talk about exercises and things, but I've never seen folks that learn the way dancers do. I mean, you give them some exercises to do and you give them a target to hit and explain it well, which hopefully I do well most of the time, although I don't know. And you guys do great. You do amazing learning it for the purposes of connecting with your body, not attaining a dance related aesthetic or position that's been taught for a different reason. So I guess in summary, what I would say is trying to ascertain whether or not the person has the full complement of postural ability. The things that are taught in a particular form of dance are specific to that form of dance and may not overlap with what humans should be able to do fully. So look for some of those stabilization mechanisms like you would in a typical lumbar spine patient, and don't be so quick to go to very complicated single leg movements like, having them get into arabesque or in penche or things like that, where those are really hard positions. Do some simple things first.
Are you ever surprised by how that you might see that real weakness in the simple things, but then they can kind of compensate and then go straight into a, amazing penche or? Yeah,
we were just having this conversation on Sunday about how strong dancers are. I mean, they're as a group, I would say that they're probably the best compensators I've ever seen. Mm-hmm. The things that they have to be able to do and the positions that they have to get their bodies into, as you kind of mentioned, are not necessarily positions that God intended them to get into. So they find a way to do it, and they use muscle groups to such advantage and to such an ability that they get so strong mm-hmm. in certain movements, and then they can be weak as a kitten in others, and it's that imbalance that often leads to problems.
Right.
And that's why I'm so happy to see the cross training and the strengthening component of the response there, because that's great.
Yeah,
so
awesome.
Yeah, no, 100%. You're right. I definitely I'm surprised. I guess I'm not surprised anymore, because sometimes I'll see a dancer that's super strong and I'll be like, what's something's weak in here? Let me see if I can figure out where it is. Yeah.
All right, so let's throw in one or two more, common conditions that people might have questions about. Can you talk a little bit about hip impingement and how this can impact a dancer?
Yeah. Hip impingement is actually really interesting in dancers, because you can have kind of classic hip impingement, which is, as I was kind of bringing up before, it's when there's either a deformity on the femur side or the socket side, or sometimes both, where they actually kind of run into each other with flexion. And that can cause labral injury and cartilage injury just from the repetitive kind of bumping up of the femur and the socket. And so you can have the kind of basic types of hip impingement in dancers, just like you can for any athlete, but you can also have a normal hip in dancers, like a completely normally shaped hip, but you will still get that impingement because you're bringing the leg into those extreme hip motions. So at some point, the femur is going to run into the socket, whether it's at a normal, less degree of hip flexion, as with classic hip impingement, or with the extreme hip motion, where it's just kind of because the bones can't go anywhere, so they're going to kind of end up bumping into each other. So you end up getting impingement and labral damage from just the super physiologic motion in dancers.
Yeah, it's amazing to see. I mean, I think the first time I'd already been a PT for probably close to a decade, and I went to the ballet for the first time, and I was like, how, like, when some of the lifts, right, where the hip is completely all the way up in flexion, and maybe even some internal rotation, and they're holding the body weight of this dancer up from, back behind the knee, like distal femur. I mean, the torque and the workload being placed on that, like, front of the acetabulum is just amazing, and they manage it. I mean, they're trained to do it. So yeah, that super physiological component of like a normal hip, like you said, is it's amazing how tough the hips of dancers become just from what they do. And even if it's hip that hasn't had problems, it has to be able to deal with those kinds of forces, which is pretty amazing. But it could lead to impingement, like you said.
Right.
For sure. How much do you see, and I don't want to get into too, like, down too much of a rabbit hole, but how much do you see, like, the posterior impingement, like
ischiofemoral?
Yeah.
Not as often as more of the anterior hip impingement, meaning the cam and pincer impingement. But if you look for it, you're probably going to find it more than you think. Posterior impingement, just maybe a lot of people haven't heard of it, but it's kind of one of the causes of pain in the back of the hip, or the posterior aspect of the hip joint. And a lot of times it's due to the shape of the hip. So the rotation of the femur and the rotation of the socket can put you at risk for kind of squeezing of those structures in the back of the hip joint. And it can be also associated with some hamstring tendonitis and issues. But it's certainly not as common. But I think if you look for it and you're going to find it a little bit more. That's why we do some testing for that routinely on my hip exam, at least in the office.
What kind of testing do you do? Just out of curiosity.
The ischiofemoral impingement test. So if you have a patient side lying, you externally rotate the leg and adduct. So bring it closer to the table. That kind of puts the stress on the posterior structures of the hip. Not commonly positive, but something to still look out for.
No, it's the kind of thing that can masquerade, right, as other problems, and
Right.
Maybe your first guess is that this is a deep hip rotator tendinopathy or a proximal hamstring injury, and you treat it accordingly, and it's not getting better. Being able to execute tests like that repeatedly and finding negatives more often is something that I probably should do a better job at, because it's when you see it, then when you get that positive, you'd be like, oh, I missed that. And so these are some of the challenges that sometimes can happen, and why the hip is such a tough area to assess and treat. It's so mobile and so responsible for forces. There can be things like this that require collaboration.
Yes, definitely. Yeah, there's a lot of structures that pass around the hip joint, not even just musculoskeletal structures. You always have to keep an eye out for other issues too, like even, GU,
Sure.
GYN, and general surgery type of things too. So lots of things around the hip joint.
Sure, the hernia problems and things like that can happen in there. Also mimic that actually comes together a lot in male dancers. Seen that a couple times with like a sports hernia and an adductor injury, and a labral tear, all together.
All in one.
And it's being managed like one, and they're not getting better.
Mhm.
And I'm not sure there's really a whole ton of consensus on how to manage that.
I don't think so either.
No.
But that's why it's important, like you were saying, to have like kind of a multidisciplinary approach, especially in this dance population too.
Yeah, agreed.
Well, we have a whole lot of hip injuries to be nervous about now. Yeah, but now we have all the information, so we're good. So let's throw in one more condition. What are the signs of bursitis? Can you talk a little bit about that, and how a dancer could treat this?
Yeah. Bursitis is hard to distinguish, I find. I don't know how you feel, James, but I think it's a little hard to distinguish from tendonitis oftentimes, because around all tendons is not all tendons, but around a lot of tendons is a bursa, or this like fluid-filled pocket that helps to cushion the area between the tendon and bony structures. And it's one of those things that, like we were mentioning before, when you have inflammation in one area, it tends to kind of impact a lot of the things around it. I don't know if you distinguish it in any way, James, or if there's any pearl you could give me.
So through some combination of palpation and symptom behavior, there's also, I was kind of on this tear for a while where I was convinced that like actual bursitis was like a myth, like in that area, like it was really mostly, it was more often than not it was glute-min or glute-med tendinopathy. But I, after doing more reading and educating myself and seeing more things, it's really, they can come part and parcel. And there are definitely how the person handles those adducted positions, what their strength looks like. If there's not the strength deficit and they're able to sustain pelvic position and they're not like dropping into a ton of adduction or pelvic drop, then I'm kind of leaning more to it being a true bursitis. I can't poke it as easily, but if I can get my finger on that tendon and clearly reproduce the symptom, and it seems very load dependent, then I kind of lean more towards it being a tendon. But I think, unfortunately, like other things, they sometimes come together, and getting a clear picture requires maybe some modification to their activity, and treating the symptoms that you see, treating the dysfunction that you see. As physical therapists, we definitely oftentimes, without the benefit of knowing exactly what's going on, we fix the deficits and the person gets better. So I try to defer to that.
Yeah, that's what I was going to ask
in
you.
cases like this,
is if you change your treatment, I guess, if you're thinking it's bursitis versus tendonitis, or treat them the same way, or if there's anything different that you would consider.
Yeah, no, if it is, so if it's a tendinopathy, if I'm leaning more towards tendinopathy, then I'm going to give them, my approach is low load, high volume exercise to the tendon. So for example, I wouldn't think first of having the person do side steps with an elastic band around their leg. Like that is single leg stance, full body weight on one leg with added resistance. That sounds like a really bad idea. I tend to put them more in gravity minimized positions and try and exercise that tendon with low load and a lot of reps to try and build the health of the tendon back, and it also depends on the acuity, by the way. So if it's really acute, they're resting. If it's that subacute sweet spot phase, then they can start to get the health back in that tendon properly. If it's more of that long-standing tendinopathy, then there's other directions to go. Whereas if it's more, I think it's more of a bursa problem, then it's more about like taping, supporting it, getting them out of positions that cause excessive adduction in stance, minimizing maybe single leg loading positions for a little while and seeing if it settles down.
All right. And James, a few of these movements that you've mentioned, I don't know exactly what they look like. Do you mind if we share one of your slides really quick? I see someone's asking about some exercises to prevent hip flexor, hamstring, or other tendonitis. So I don't know if any of those apply.
Absolutely. So what I did was prepare some slides that are these aren't specific to any particular injury. What I wanted to do was just kind of go through the kind of the thoughts that should be behind planning an exercise program, and how you evaluate where a person starts this program is what's so important in my experience. It oftentimes therapists either way underload or overload the problem, and maybe don't start from some of the basics. And I think we all can be guilty of this at times. A very experienced athlete, dancer, someone comes in and we say to ourselves, well, this guy obviously knows how to do a bridge. Like, they know how to do some simple things. Like, we're going to start them with, a single leg bridge, like that bottom left one, right? So I typically start with my exercises when they're ready from the ground up, not in standing. And really, this kind of goes back to the question earlier about motor control and assessing how well they do things. Seeing how the person executes that bridge. If they can't do that first top left picture without pain or without problems or without massive loss of lumbopelvic position, then I'm not going to move them onto the bridge where they lift one leg. So that second picture, the person would have come up into the bridge and then hold it, stay there, lift one foot, put that foot back down, reestablish their position, hold the bridge, and then lift the foot again. Whereas the next picture on the bottom left is the person actually executing the bridge on one leg from the ground, which is very hard. And so I don't go into things like that. The sequencing here is my point on this slide. And then you can get into funny things like this other one where the guy's holding the ball and there's some core activation involved. This might be an exercise that would be a late stage exercise for somebody with a snapping hip type problem, because here they get to engage, if they're doing it properly, they get to engage their abdominal wall, maintain a lumbopelvic neutral position, and then bring in the stabilizing role of the psoas in that flexed position. Whereas some of these other positions are maybe a little bit earlier on, where they can lift the leg with a bent knee, which puts a little bit less stress on the psoas and make sure they can get that flexion movement back. So where is your patient? Where do they fit? And this was kind of my point with this exercise. You can go to the next slide. And then from bridging positions, I start getting into closed chain or more upright closed chain positions, like a Pallof press. Before I go into standing, a simple thing to see here is if you put somebody into half kneeling, which is a really great way to start to check how they handle hip stability when they're loading it in a closer to standing position. And what this guy has is he's got a cable off to his right, your left for the viewer, and that cable is trying to pull him off to the right. And the picture on the left, he's having a hard time holding himself upright. His hands are getting pulled over. He's losing his form. Once somebody can get to the middle picture, then it's time to start going into some standing things. So understanding where your patient lies and taking them through a sequence of movements that makes sense, matching what they can do with the tasks that you're giving them. So you can go to the next slide. So again, just saying here, how you're progressing your lower body strengthening. Before I'm going to one leg exercises, can they execute these two leg exercises? You can go to the next. So these are some criteria that I use again for progressing to single leg training. So if you're a person who has hip pain or a therapist treating them, and you can't check off this stuff, and you're wondering why the hip pain's there, then this could be a good reason to go back to double leg standing exercises, because it's half of your body weight, right? So you can take the load down and maybe execute the exercises properly for a period of time and then come back. All right. Good, you can go to the next. So then you get into exercises like this, which are a lot more complicated, where you have the person balancing and standing on one leg. Like, I would never bring somebody into this position if they weren't checking off all of those boxes. And this is a great exercise for more aggressive hip stabilization, for more advanced hip stabilization. This person is over into a front fold, a front T with their arms out, and when they're maintaining that position and raising and lowering, alternating arms. So they're bringing in other planes of the knee to stabilize while they hold that position. Tough exercise. So how do I get somebody to this point? I've made a couple of videos. I tried my best to do my own exercises. Let's see how it goes. So you can, I think that's the next, right? So this is where often I start people, because the ability to maintain the control of the deep hip rotators in positions that are less threatening to the hip, I start here. So what I have is a cuff on my ankle, and there's a band attached to that wall. So this is a piece of therotubing, and my knee is on a spin disc. These are commercially available. You could also just do it on a rug with like, you can play one more time. You can do it on a rug with like a plastic disc, but something that allows that femur to rotate. So now I'm in a position where the ball should be seated a little bit further back in the socket, and I'm working on controlling those deep hip rotators. And then next picture, next video. This is similar exercise, but now we're up and standing. So I'm on a kneeling stool. Again, you could do this with a step maybe and a towel that could slide, but I'm trying to execute the same movement, working on the muscles that control rotation around the hip in a loaded position, but I'm not fully loaded on it yet. I have it in a little bit more of an upright standing position than I did before. So challenging those muscles to do their job when the hip is closer to neutral. But I don't have full load on it yet, and you can kind of progress the patient to load this more and more before you get into things like the last two exercises. So this progression that you're seeing probably would take maybe 6 weeks or 8 weeks with somebody, depending if they're post-op, maybe even longer. So now we're going into a step up with rotation. And what I'm trying to have the patient do is rotate that pelvis while they're single leg loading on that one leg, not go up and then rotate their pelvis, or come down and then rotate their pelvis. You want to get control of that rotation of the hip in loaded positions that more mimic what has to happen with dance. Like you push off and do a turn, your body's twisting as you push through that leg. You really need to have control of those deep hip rotators as you're pushing, and using some of those bigger muscles like your glutes and your hamstrings and your quads. And then the last one is where the last video is where I take people later on. So flipping over a Bosu and going into single leg stability and executing a penché or a step down, and just being able to work on really bringing in a more dynamic stability capacity here by having a floor that's moving around and challenging the person to be able to use those hip rotators effectively while they're using the big movers to get themselves up and down. And then you can play around with this. You can add weights, you can add changes in direction a little bit as the person gets better, but this really brings in those deep hip muscles and gets you to be better, stronger at stabilizing that hip around the socket. So I guess my point in all this was kind of, these are the kinds of exercises that I use to help somebody get a more stable and controlled hip. Are there others? Yes. For specific problems? Yes. But these are the kinds of things I would expect somebody to be able to do, starting from simple stuff like a bridge, and then moving your way up to challenging those rotators and stabilizers in other positions.
All right, thank you. Yeah, that was really helpful to have the visual, and now we know some exercises we might practice, or if we visit a physical therapist. Being mindful of time, let's throw in one more question. Dr. Buza, how would you differentiate between a hip injury and hip weakness? I know you touched on this a little bit, but for anyone who's wondering.
Yeah, so I think it comes down to the exam a lot of times. So when we're examining you, we're going to test for specific things to look at the labrum, some impingement testing, as well as some instability type testing when we're evaluating you. That being said, that you have to know when to to go in for an evaluation when you know I think if anything is lingering. Of course, if you have an acute injury, then a fall or you're landing from a jump and you felt something wrong happened, then that would be a reason to be seen sooner rather than later. But if you have an injury that really you can't kick it, it's starting to interfere with your dancing. Certainly, if it's starting to interfere with everyday life, then that's when I would come in for a real focused hip physical exam to try and differentiate between that weakness and a true injury.
Well, what do you see in your practice? Because a lot of times most of the time they come to you first before they get to us. So it's a little bit of a delay when we get to them. So how often do you see injury, whether it's acute or subacute or more repetitive, whatever it may be, injury that like clearly injury where a hip is still strong?
I think, well, certainly if it's a very acute type of thing, so a traumatic type of injury, that's when I think you see it the most. But I think what you're bringing up a really good point where it's usually something is weak, either that makes them develop the injury to begin with, or because they've been trying to compensate for so long with more of these chronic subacute injuries, that's when they're developing more weakness. So yeah, you're right. It comes together a lot of times.
Yeah,
but
the hip.
If you revulsed your hamstring, then you're probably still
right.
That's more of a reason.
And the hip is such a stable joint, right? For the most part, the like what you just said, and I'd love to hear more of your thoughts on that about the compensatory capacity. Like people are able to continue doing a lot of things with a hip that's weakening in certain patterns, and then structures just start to suffer.
Yeah, that's a really great point.
All right. So now any final words of wisdom for dancers that are looking to keep their hips healthy and strong? Any final words?
I think what we've talked about a lot, I think it's really keeping every muscle, everything strong and stable around the hip joint. So really taking everything that James has talked about. And if you want to come in for an evaluation from a physical therapist, but I think it's really about that cross training, strength training, and being mindful of your body and the limits.
Yeah, and I'll add to that I think people are starting to get there. I've seen a lot more interest, and it's represented today in the poll response. What I think could be better is getting that trust relationship with a physician earlier on. As physical therapists, because we get into the nitty gritty with things, I think we get that kind of trust with the dancers when they see us pretty easily, and a lot of times they come back to us and we wish they would have. We'll refer them, but maybe they haven't seen the physician. And I just want to say there are so many physicians now that have dance experience, like Dr. Buza, who are they are extremely knowledgeable and will help you right off the bat to get this taken care of and understand the importance of getting it taken care of properly, and give you that medical diagnosis and that information that you need to kind of elevate the importance of taking care of yourself properly. While we can help you as physical therapists, sometimes if we don't know exactly what's been going on, we continue to revisit one of the same problems over and over again. Get in, see a doc when you have something going on, and build that relationship early with them like you do with us, because that way, if it's another injury, unfortunately, or something comes up 2 or 3 months later, you have somebody you can go to. Don't wait and come in with things having continued for months when they could have been better evaluated and identified early on.
Yeah, thank you for saying that. We're totally here for you, and we understand what your demands are. So, we're always available and more than willing to help you.